Now, when I see Dr. Besser here in the audience, Dr. Rich Besser led our Center for Emergency Preparedness and Response when I was at the CDC, and we went deep on preparedness in terms of planning and exercising and investing and so forth. But I think looking back on it, we thought of it as a health crisis, and we approached it as a health crisis. We concentrated on the medical and the public health dimensions of it. We didn't think so much about the economic crisis, and we didn't think so much about the social consequences and the inequities that were part of what we're experiencing right now in the context of this pandemic. What that really says to me is it's a whole of government responsibility. And so I guess part of the issue is, how does CDC fit into this much broader governmental context, and how do you negotiate your unique role and yet at the same time participate in the intra-agency process?
Yeah, that I think has been something that I had to learn quickly and is so key, because we will say we lead with science, and we do lead with science. But as we make policies, we can't ignore the fact that these are interagency policies. So how does our school guidance intersect with the plans of Department of Education? How does our infection control and prevention guidance intersect with what labor is doing, Department of Labor is doing? How does the eviction moratorium intersect with housing and urban development? And so almost every decision that we have made in the context of a pandemic, in our guidance, in our decision making, has brought, and those are just several brief examples, has brought interagency collaboration, important policy intersections that we have to take into account as we're making these guidances and recommendations.
So can we keep going in that direction around the work that CDC is doing for epidemic preparedness and response, pandemic preparedness and response? I mean, obviously in this pandemic, many things have been happening, and when things don't work, they may be called out, but they're not always called out when things are working. And so can you say a little bit more about the things at CDC where you think, even as you're looking at your reform agenda and what you're thinking about changing, where do you think CDC's biggest strengths are, their assets are?
Yeah, maybe I'll talk first. I think we should just acknowledge that in the last 19 months, we have delivered 600 million vaccines to Americans. That's kind of extraordinary, with a vaccine safety and effectiveness profile that has been rigorously studied from moms and babies and infants. So that in and of itself is something that I think is underappreciated, what it took to vaccinate, we can call it 75% of America. So that I think is something we should acknowledge. In terms of the work that we're doing and have been doing, there have been numerous things when I started as an admirer of CDC from the outside. I could also say that these were challenges that I perceived as the outside. Our science needed to move faster. CDC had been long criticized for our science not moving fast enough. So how can we get things out faster, our clearance process out faster? That was something I addressed early on. Equity, clearly a challenge in the pandemic. And this was something that I know that all of CDC actually believed in, but we had this moment to do more for health equity. And actually it was one of the things that worked to boost the morale most of the agency when I got there, was to talk about equity, to mobilize around social determinants of health, around a core strategy for equity, around addressing diversity and inclusion within the agency and outside of it. Data. I'm a data geek, so data has always been important to me. We launched the Center for Forecasting and Outbreak Analytics, which was really important to think about innovation, data sources, how we can project, how we can forecast, how we can work with our partners, what do they need in terms of forecasting, and I'm really excited about this new center. Also in data, I don't know that everybody recognized as an infectious disease doc, when you report something to the CDC, it was a handwritten form that you send and say, this patient has measles or this patient has tuberculosis. In COVID, it was 1 million a day. We were getting reports to the tune of 1 million a day, and some of them were literally coming in by fax machine. That's not a data system. And so we really went from case reporting of 187 places to 15,000 healthcare facilities that we're now reporting data electronically. So we've really scaled up our data systems. And then maybe one final, because Julie, you mentioned communications, and that is, I started and we had a communications director position that had been opened and vacant for 4 years. We posted it twice. We've just had that hire in the last couple of months. Kevin Griffiths, I'm really excited, is now with us. But that's been challenging. There's no question.
So, you're mentioning this data systems problem, but a lot of people don't really understand what your authorities are from the state and local level. And I think it's really worth emphasizing that you get data by being a good partner, but you don't really have the authority to require it.
No, and thank you. So there are two major challenges, I would say, with data right now. One is the pipes don't connect. Like data coming in from one state or even one county doesn't connect to its own state, doesn't connect to CDC. And even if it did from that singular state, it doesn't match the pipes from a different state. So if one jurisdiction was to send data to us, we can't send a similar jurisdiction back to see how they're doing comparatively. That's problem number one. Problem number two is even if all the pipes connected, there's nothing flowing through it. And so through, having come in the middle of the pandemic when we had the public health emergency, many of those systems started coming in because through the public health emergency, we got some of the authorities for the data to come in. But you are exactly right. We do not have the capacity to compel data to come in. We get it voluntarily. We did not get it from monkeypox. We are just now able to get vaccine data from jurisdictions through 64 legal teams working on data use agreements each time so that we can get those data in, and they're now just starting to flow. We can't make real live nimble decisions when 3 months after a first case we are first starting to see data. So it's both of those issues. We can work on the systems issue. We need the authorities issue. And we need the partnerships, because I really do want to say what I'm not interested in is mandating data from jurisdictions. What I'm interested in is a bidirectional highway where if data are to come in, we have a responsibility to give it back in a way that's helpful to the jurisdictions as well.
And I think that's tough because it's as you said, the pipes don't match up, and just linking one healthcare institution's data to their local public health department is a huge challenge, let alone trying to construct such a system for the entire country. But the idea of a data commons in public health is, I think, an idea whose time has come.
And we're actively working on it.
Yeah, it's really important, and we need congressional help with
yes,
that.
we do.
Absolutely.
Yes, please.